Hello, I'm Matthew Hood, Vice President of Government Relations at Dartmouth Health. Government Relations is so pleased to roll out the 2022 We Care, We Vote initiative. We Care, We Vote is a nonpartisan voter education initiative designed to encourage participation in the 2022 midterms. We do this by providing information on registering to vote and voting in New Hampshire and Vermont. You can find these resources on the Dartmouth Health website under Health Policy. As a 501c3 organization, Dartmouth Health does not engage in election intervention activities, meaning we don't tell people whom to vote for, but we do invite all candidates for discussions so that we can learn where they stand on issues and have an opportunity to ask questions. I want to thank you for your engagement and remind you to vote on November 8th. Well, welcome. My name's Matthew Hood. I'm the Vice President of Government Relations here at Dartmouth Health, and I'd like to welcome viewers to the latest session of We Care, We Vote Health Policy Grand Rounds. Today, I have the pleasure of honoring Congressman Peter Welch, candidate for U.S. Senate from Vermont. Congressman Welch has served in as Vermont's sole representative in the U.S. House since his election in 2006. He serves on the House Permanent Select Committee on Intelligence, the House Committee on Energy and Commerce, and the House Committee on Oversight and Reform. Welcome, Congressman.
It's good to be here, Matthew. Thank you.
So you've been representing Vermont in Congress since 2006. Could you tell us a bit about your experience and why you're seeking a move to the Senate?
This is an extraordinarily challenging time. We're going to be talking, of course, about healthcare, and Dartmouth-Hitchcock is just a crucial institution for the well-being of so many people in Vermont. As I understand, about 40% of DHMC's patients are from Vermont, and many of your employees, of course, are from Vermont. I have been involved in working with DHMC in healthcare response since I've been in Congress, and even before that when I served in the state Senate. But just to step back from that for a moment, where I know we're going to be talking about that quite a bit, it's really a crucial moment because of what happened on January 6th and all that embodies and all of what it portends. That was the first time in our history where there was a violent effort to thwart the peaceful transfer of power. And that has grave implications for the future of our democracy. And January 6th was not the end of that effort, it was a beginning. So our democracy is very much on the ballot. We have to have a Congress that is going to make certain that the tradition that we've had in this country of the peaceful transfer of power is reinforced. And that's going to take a Congress that elects folks who are not going to be second guessing the decision of the voters when it comes to who the voters elect to be president of the United States. And that democracy is really essential because it's the tool that we use as a society and have over the centuries to resolve those conflicts that are really fierce and difficult to resolve in our society. And it's a form of governing where everybody has a seat at the table. Points of view can be expressed and debated, but outcomes are through the democratic process where people have a say as opposed to an autocratic process. So, in fact, that's what's different in this election than in any election I've run in before. So I think that's something that we all have to keep at top of mind.
Thank you, Congressman. And you actually anticipated at the beginning of your answer to that question my next one, which is just to say that two things. One is, as you know, Dartmouth Health and its members, such as Mount Escutney in Windsor, Vermont, have been on the front lines of the COVID-19 response in the region. And the pandemic has greatly impacted a number of things with respect to Dartmouth and other healthcare providers, fiscal health, care delivery, the communities we served. You lived through this, and I wanted to reiterate my appreciation for your support during that period of time. Thank you. But I'm curious as to a couple of things. One is, what additional steps do you think might be appropriate for Congress to assist with the fiscal recovery of hospitals, acknowledging again the assistance that has been provided to date, again, which is greatly appreciated?
Well, first of all, I want to acknowledge the incredible work at DHMC, the providers there, the physicians, the the nurses, of course, the assistants, everybody who was there was under an immense amount of pressure. In March 2020, essentially our economy went on shutdown, and a lot of people who had jobs were not allowed to go to work. But there were some people who had jobs that had to go to work, and that was folks in the healthcare field. So while all of us were apprehensive about what was going to happen with COVID and our own well-being and the well-being of our families, we had folks at DHMC who, in addition to sharing that anxiety, had to show up for work, where the people who would be coming for you to treat and care for were folks who had COVID, a highly, highly transmittable disease. So I just want to acknowledge my appreciation for the extraordinary work that DHMC, your employees and staff, provided over these last couple of years. Our job in Congress was really essentially to try to provide the resources to support the effort that DHMC was making to treat people and put themselves in a position to be able to provide the care that was necessary. And that's why I was very, very supportive of significant funding supplements for our hospitals. The hospitals were really on the front line. We're coming out of COVID, but there was a real hammer, financial hammer, an impact on our hospitals. I mean, when I think about some of the things about how staffing shortages were really severe, how people had to work many, many more hours than normal, how they were stretched really thin. And that was during a time when childcare was shut down, where the expenses accelerated with an immense additional burden for paying for the expensive travel nurses who we needed, but where a lot of that expense was going to hedge funds in New York who were kind of exploiting the situation. So the financial situation for our hospitals continues to be precarious. The need for hospital services continues to be great. So I will continue to be supportive of doing things that take into account what the COVID impact was during the height of COVID and now as COVID is waning but not disappearing. So I would continue to be supportive as I have been in the past.
And you have, and I thank you for that. And you touched on a couple of items. I'm going to take that opportunity to transition to one of them a little bit in more detail. But as you alluded to, it's not just the financial challenges in terms of emptying out the beds to make room for the original surge, but the workforce challenges, supply chain issues, as well as flexibilities and waivers that Congress and CMS put into place, which were incredibly helpful and are still in place, obviously, as we have the public health emergency. But I'd be curious as to two things, your thoughts on two things. One is the continuation of the flexibilities with respect to telehealth, for example, that have been put into place. And what can we do? What can Congress do with respect to the workforce challenges that we have? Because I think that's like the $6 million question.
Well, two things. First of all, telehealth is really, really proven itself to be so extraordinarily beneficial, both to patients and to providers. And I'm not sure you know this, but I was the Democratic head of the telehealth caucus. I mean, prior to COVID, there were many of us who represented rural America that we're hearing from our providers and from our patients that, hey, this is just really tough to get from where we are to where we have to go for an appointment. And we started out telehealth in the VA to try to ease the transportation challenges that a lot of our veterans had getting up to the VA in White River. And we were making the case pre-COVID that, hey, telehealth really works. Of course, you have to have high-speed and high-quality internet to make that happen. But that's been part of what has been deployed during COVID. And what we have seen with telehealth is that it really, really works. It makes it so much easier for the patient to get to an appointment. The provider has direct contact. And a lot of the early concerns about telehealth, that it just wouldn't have the patient provider interaction quality, those disappeared. That is an intimate interaction. You've got to make exceptions. Obviously, we're not talking about getting rid of the direct in-person contact, but where the person who shows up, the appointment starts on time, they're not in a waiting room, they don't get exposed to potential other illnesses. It all really, really worked well. CMS is pushing back a little bit because they're asking a question, will it be abused? Well, that's a fair question to ask. But you know what? That question can be asked about the delivery of any service in any manner. So yes, let's make certain that we put in place protections to guarantee that the service provided is the service delivered. But why isolate telehealth as a delivery service that's subject to more severe scrutiny when in fact it really works for the benefit of the patient, for the benefit of the provider? So I will continue to be a very, very energetic advocate for the institutionalization of telehealth.
Well, we appreciate that support. And I would reiterate, particularly at the outset of the pandemic, we had a significant increase in the utilization of telehealth, whether it was audio only for the exact issue that you raised with respect to broadband capacity challenges in rural northern New England, which some of the infrastructure bill has allocated funds to address, but it's certainly still a challenge. And then it's plateaued. I think we've seen it come down, utilization for telehealth. And yes, further study is necessary to determine access. Has it improved access? Is it increasing utilization, or is it in lieu of? I think all of those things are looked at, but I sure hope that we look at those while we're still providing and covering telehealth. That would be my hope. So I know I have a number of questions here that I'm not going to ask, but I'm going to state what they are because I know your answer, and so I appreciate that support. We have proud recipients, researchers who receive grants from the federal government for. We're connected with Geisel and Dartmouth College and the medical school, and then researchers, clinical researchers here. And I guess I would reiterate my appreciation for your support in that front too. If you wanted to say anything about that, please feel free. But I know that you've been a supporter of that, as I know that you're a supporter of Medicare, and as we see the reduction of the time frame from the most recent Board of Trustees annual report showing a 2028 depletion date. I want to give you the window to speak to those two things, but I also acknowledge your support of both of them at the outset.
Well, thank you for that. I do support Medicare and Medicaid. Medicaid reimbursement rates are way lower and have to be boosted. But there's always, I want to say this, we're going to, whatever it takes to keep Medicare intact, we have to do, period. And on the government side, we've got to make sure that the funding is there. And of course, Medicare is largely paid for through our payroll contributions as we are in the workforce, and then still we pay considerably for Medicare when we are on Medicare. So I want to make sure that the funding stream continues and is strong, and every citizen can be confident in this country that Medicare will be there for them when they become eligible, and that those who are on Medicare can continue to have confidence that the care will be provided. It does raise a question about the cost of healthcare, and that's an issue that is got to be addressed. We pay the highest in the world for healthcare, and we can't sustain that. But part of the way we have to address that is to go to places where there really are market distortions. You don't have much control in a hospital over what your costs are. And in many cases, you don't have much control over what the reimbursement is from Medicare and Medicaid, particularly, but then dealing with insurance companies. You don't have much control over what the cost of pharmaceuticals are. And those have been escalating just immensely with the incredible pricing power of pharma. You don't have much control over what you're charged by hedge funds that have been buying up staffing agencies that provide travel nurses. And that Wall Street premium is really, really significant. So a part of our approach here has to be both on the revenue side, make sure the money's there to pay for services and to pay what is required in order for the provider or the hospital to deliver those services, but also to look at places where the market distortions have raise prices beyond anything that's reasonable, and I'm talking particularly about pharmaceutical prices as an obvious example. I was the sponsor for 16 years of the effort to give the government authority to negotiate prices on pharmaceuticals, not set prices, but negotiate prices. We pay the highest pharma prices in the world. And, part of what we did pass in the Inflation Reduction Act was to give the government authority, Medicare, to negotiate fair prices. And by the way, that'll mean that there'll be a cap on insulin prices for people on Medicare at $35. A lot of times the charge was around $300. So, summarizing this, we've got to focus on a revenue stream that's sustainable, and we got to focus on lowering costs where they're unreasonable.
Thank you. I mean, there's so many interesting topics I want to dive into in that area, but I'll just reiterate one, which is because I think you articulated it so well. Inflationary costs are impacting the expense of delivering healthcare, right? So
right.
on one hand, you have this. We're pretty limited in what we can do in terms of revenue in that space, both with respect to government payers and the ability to negotiate with commercial payers. So we don't need to belabor that point, but thank you for articulating it, because I think that points out a conundrum that we're facing right now.
Right. Thank you.
So we have, it was the substance use disorder and mental health challenges existed prior to the pandemic. The pandemic, I don't know that they certainly didn't go away, but I think we, in fact, in some cases, exacerbated those challenges, and they're now coming again, bubbling up to the surface as we come to some sort of new normal with the pandemic. I don't know if anyone would accept that description other than myself. And so, what are your thoughts about the behavioral health crisis that we have, particularly in Vermont and northern New England? I mean, I think we've seen some significant spikes in overdose rates, of hospital visitation as a result. How can we get our hands around this challenge?
Well, I wish there was an easy answer, and we all know there isn't. What you just mentioned is not just in Vermont, New Hampshire, and northern New England. This is nationwide. And it's one area in Congress where, despite all the division that we have, there has been significant bipartisan cooperation, because the scourge of opioid addiction knows no political boundaries. It knows no economic boundaries. And the escalation in the tragedy of fentanyl deaths, for instance, opioid deaths, is, I think, been aggravated by the isolation that so many of us have felt, so many of our fellow citizens have felt during COVID. That was a tough time. And if you were isolated and you didn't have access to friends and a community support structure, it created a lot more vulnerability. And I think that's an impact from COVID. There's two approaches. One is there's got to be funding from the federal government to help our local providers and counselors provide services to folks who are ready to take that step and become released from opioid addiction. That is hard for the individual. It's a powerful hold an addiction has physically, not just mentally, on a person. But the effort to provide that care to that person has to be provided at an intimate and local level. That requires funding from the federal government, and we've substantially increased funding for that. But secondly, as my colleague, the Republican head of the Energy and Commerce Committee, Kathy McMorris Rodgers from Seattle, says, opioid deaths are deaths of despair. And to some extent, it says to me that we have to do everything we can to rebuild our communities. When we have an erosion of downtowns, when we have an erosion of community associations, when we have an erosion of what mutual support is provided, when you're working in a good institution, let's say, like DHMC, or you have colleagues and friends that you're seeing on a regular basis in the community, where there's jobs that are close to where you're living, where you don't have to live an hour from where you work because of the affordability crisis in housing. trying to revitalize these communities so you have day-to-day associations with people who can provide you with some support and where you can help others who may benefit from your support. That's got to be part of it, and that's a long-term regeneration of our communities. So it's those two things. One, help for the individual who's ready to make that step and try to deal with the opioid addiction. And number two, building that community support structure that's just in the world we inhabit.
I want to give you an opportunity to talk about anything I haven't asked about. I have a long list of topics that I could talk about if we had unlimited time, including social determinants of health, diversity, equity, inclusion, and belonging. But I really want to give you an opportunity to speak to anything that you'd like to in our remaining time.
I want to just acknowledge my appreciation and the appreciation all of us have in Vermont of the importance of DHMC in the well-being of Vermonters, in the well-being also of our economy, with so many Vermonters working at DHMC and so many more Vermonters getting their treatment at DHMC. And I want to particularly salute the staff. All of us during COVID were anxious about ourselves and our families, people we loved. And there was that whole period where it was completely unknown, pre-vaccine, where it was almost impossible to imagine how you'd escape the virus. But you had to show up for work, and you had to be there for when for us when we did get sick. And I just have to say that's extraordinary, because you shared, each and every one of you at DHMC, the anxiety every American shared. Most of us were able to isolate at home. That was hard. You had to go to work and be there when at the beginning it was completely unknown, and be there to help us get through this. So thank you so much. And I felt so blessed to have a job where I could, in Congress, advocate to make certain that you got the funding to support the services that you were bravely providing. So it helped me get through COVID to have this opportunity to be a partner to you, doing my job as you were doing your, I think, much harder job. So thank you.
Thank you, Congressman. I really do want to emphasize our appreciation for your support. I actually will take this opportunity also to say that in my role in government relations, I actually enjoy the opportunity to support the work of the frontline people. That's a really, that makes me proud to come to work. And so I appreciate you saying that. And it's been a pleasure to chat with you.
Likewise.
And I look forward to additional conversations.
Thank you very much.
Thank you.